afternoon. This is Dr. John Bennett broadcasting from Bharatnagar, Nepal in the ACNS weekly Neurosurgery Student Society webcast. And today we have the pleasure of having Mohammed Tariq Imtiaz, MD, from Saudi Arabia. He's going to speak on modalities of Neuro Electrophysiology and neurosurgery. And we're joined by a couple of guests. Let's introduce them first before we turn it over to Mohammed. Good day, Hira.
Hello, good day, everyone. This is Hira from Pakistan, Karachi. I'm one of the youth leaders organizing this ACNS educational courses weekly. I hope you enjoy this today. See you in the next week as well.
Very good, Hira. She's a big force behind these talks. And Rakesh, welcome back.
Hi, I'm Dr. Rakesh, a neurosurgery resident from India. I'm very glad to be a part of this presentation. Thank you, everyone.
Welcome, Rakesh. And Simon, could you please say hi, please? Okay. Simon is on mass transit in Japan, and they're really not allowed to speak too much, so we'll respect the cultural differences. And okay, Mohammed, welcome, and it's all yours.
All right. Hello, everybody. This is Mohammed Tariq Imtiaz from Riyadh, Saudi Arabia. It's about 1 p.m. in Riyadh, and I'm going to switch to the screen.
Can you talk a little bit, Mohammed, about your background, what you do, etc. first?
Yeah, I basically am from Karachi, Pakistan. I graduated from Dow University of Health Sciences back in 1998. Then I went to the US, did my training in neurophysiology from there, became a fellow, board certified and fellow from there as well. I had lived in the US for about 11 years. Before I moved to Saudi Arabia in 2010, King Fahd Medical City. And since then I've been, part of King Fahd Medical City. Can you guys see? Can you guys see the presentation yet?
Yes. There we go. The full screen. Perfect.
Okay. So as you can see, the title is Neuro Electrophysiology Modalities of Brain and Spine Surgeries. I work in King Fahd Medical City, which is the largest tertiary care medical facility in the Middle East. We're going to have about 2,000 bed hospital, the largest neurosciences center with more than 350 beds. It's in the pipeline right now, but we're still the largest already with about 1,300 bed right now, and the largest neurosciences center in Saudi Arabia. This is hopefully is going to be my amongst the other talks, this will be the first talk, hopefully many more to come. Okay, so this is the place where I work. This is the CEO of our hospital. He's a neurosurgeon. That's why I put his picture in, and he's a great believer in Neuro Electrophysiology. And he was the primary reason I arrived from the US to this hospital, and since then I've been here. Just to introduce you in a couple of minutes to our hospital. Can everybody see all these pictures?
Yes, we can.
Okay, so this is the brain suite that we got in 2005. This hospital started working in 2004. And this is in 2005. I think we were the 5th hospital to get this brain suite, and we operate routinely in this room. As you can see, the setup. You can see some of our residents, the screens. Very nice setup. This is one of the recent cases we did. A brainstem tumor last week. As you can see on the right side, I'm sitting with the machine. Another neurosurgical room that we have. You can see very spacious rooms that we have here, and I love working here. You can see all these screens, so I love watching all those direct videos coming into me when I'm sitting there in those ORs. There's another room with the CT scanner. You can see that. There's another room with mobile CT scanner, with the O-arm that we call it. So you can see that this hospital believes in technology. And of course, Neuro Electrophysiology is one of those technologies. The crux of my talk is to focus on patient safety. Why Neuro Electrophysiology was started. This is all. This is the bottom line. Patient safety should be a part of healthcare policy. And this came up from the Institute of Medicine in the US in 2013. So the objectives after this, from me is for students or younger neurosurgeons or surgeons who do not have that much of exposure about neuro-electrophysiology, is to introduce them to a little bit of neuro-electrophysiology in relation to neurospinal surgeries. In basic concepts, briefly, what are the modalities, what tests that actually do, what exactly we do, and then I'll give you some of the videos of how data changes are interpreted from some of our own surgery videos from National Neurosciences Institute, King Fahd Medical City. Okay, so the first question everybody would ask would be, what is neuro-electrophysiology or intra-operative neurophysiology? You see those words in the bracket. Some people use IOM, that is the same thing, intra-operative neurophysiology monitoring. NIOM, again, the same thing. So it depends on where you are. Some people like to write it IOM, IONM, NIOM as the short form of intraoperative neuroelectrophysiology. So this is the use of certain electrophysiological and vascular monitoring techniques to allow for early warning, avoidance of injury, maintenance of functional integrity of neural structures during surgery. So the important part is this is real time. While the surgeon is operating on a tumor, for example, he has the real-time information about the sensory motor system, the root system, the nuclei in the brainstem or in other brain nuclei, the corticospinal tract. He gets the first-hand information immediately as he's working on the tumor. So you can imagine this information really helps him in achieving a successful or a more thorough surgery and a more safer surgery. So as I just mentioned, these modalities, and I'll get to those modalities in the next few slides, these modalities, they identify changes in brain, spinal cord, peripheral nerves, to increase, as I mentioned, patient safety and improve outcomes, and ones of serious complications in time. You know, for example, in the neurosurgical OR, time is of essence. Identifying a change in real time immediately can have much better outcome than actually identifying a change after the patient has woken up from the surgery. It also identifies systemic problem, for example, a drop in mean arterial pressure or hemoglobin drop, or the pH changing into more acidemia, you can say. Those changes that result in physiological changes in the nervous system can also be identified. Mind you, these changes are not depending on a surgeon. This is anesthesia is taking care of these changes. So when these changes are identified, you know, there's a certain way you read them and you communicate not to the surgeon, you communicate those changes to the anesthesiologist. So again, providing a degree of neurological safety with more thorough procedure, allowing procedures on high-risk patient, of course. So just to give you a little bit, I don't know whether people can see this picture. I hope they can. If you see this on the left side, King Fahd Medical City, the left top, these are the accredited IOM laboratories in the world so far. And you can see this, we are the only one outside of the US so far. And they have Stanford there, we have Johns Hopkins there, University of California there, you know, many top-notch universities are there, and we are the only one outside of those universities that are accredited to do intraoperative electrophysiology. Okay, so what are those modalities? So there are many modalities. And depending on the cases, I do at least 5 or 6 of them in almost all of our patients. I'll give you all these names, and I'll get to at least 4 of those today, hopefully in 1 hour's time. If I have more time, I can go more. And I would suggest to students that they might want to write questions if they have, and we can get to questions part hopefully after towards the end of my talk. So the standard modalities that are used, I've given them here. Somatosensory evoked potentials. I don't know whether students are aware of that. I'll give you an animated video of what is somatosensory evoked potentials in a little bit. So those who have not seen them, they can understand, those students, I mean. Then transcranial motor evoked potentials. You can imagine just by the name that the somatosensory evoked potentials, you are testing the somatosensory pathway. Especially, I'm only confining somatosensory pathway to dorsal columns. So we're basically monitoring dorsal columns. And then transcranial motor evoked potentials, you're monitoring the motor system, right from motor cortex to corticospinal tracts to spinal cord, and then nerve and muscle. So the whole system is monitored through certain tests, and I'll show you how. And then this is pretty high-end, sensory, the number 3, sensory motor mapping. For students, I hope they would understand. I'll make it easy by the animated video that I've prepared especially for this. What is sensory motor mapping? Phase reversal or motor evoked responses. What happens is that those tumors that are located on the homunculus, you know, the famous Penfield homunculus, and when the tumor is located on that, on those areas, on that homunculus, sometimes those areas are obliterated. The normal anatomy gets obliterated, and the tumor is sitting there. So when the surgeon needs to remove those tumors, he needs to map those areas to identify where is the sensory cortex, where is the motor cortex, and which areas on the motor cortex are supplying hand areas, and you know, all of those things. You know by anatomy, by the homunculus, but we electrophysiologically test them during surgery when the patient is sedated, and we identify those tiny little millimeters of structures, and we tell this to the surgeon that this is the hand area, please do not remove the tumor from there, because then the patient would have post-operative weakness on those areas. Then we mapping and monitoring of brainstem nuclei, cranial nerves, and cortical spinal tracts. You can identify those as well. We do direct spinal cord stimulation, D waves. Now, you can imagine just by the name, just using common sense, direct spinal cord stimulation is used for spinal cord tumors. Also D waves. D waves are direct waves, and direct waves meaning that we stimulate proximal to the tumor on the central nervous system, and we record on the central nervous system distal to the tumor. So this is a very important wave in intramedullary tumors, and where these waves can actually help us in achieving maximum resection without deficits. Then, of course, the famous terms of EMGs and triggered EMGs. EMGs are spontaneous muscle, nerve activity which you record from the muscle, and then triggered EMG when you sort of create a response. There is a difference between spontaneous or free-running EMGs, comparing it with the triggered EMGs where you create a response. Normally, we do triggered EMGs in, say, quad aquina cases, where you stimulate a nerve, for example, a nerve to quadriceps or nerve to anal sphincter. You stimulate that nerve to identify that nerve and to create a response. Then direct nerve action potentials, we do that in brachial plexus or peripheral nerve cases, and then mapping of DBS. Deep brain stimulators. All of these modalities I do in our setup, in our patients. And these are the surgeries in KFMC, in National Neurosciences Institute in KFMC, where we use those modalities. And hang on there, guys, the students I'm referring to. I'll get to those modalities just to give you a little bit of 4 or 5 slides of a little bit of introduction of background. So all of these surgeries require, or at least in our setup, we monitor. So you can see scoliosis surgeries are there, sacral surgeries, lumbar, thoracic, you name it. And then I sort of label them as advanced spine surgeries, where a little advanced techniques are involved. For example, selective dorsal rhizotomy for spastic diplegia patients, tethered cords, spinal cord tumors, peripheral nerve tumors, spinal AVMs. So these are the spine surgeries where the use of intra-operative electrophysiology is recommended. And then in brain surgeries, we have surgeries on eloquent areas, as I mentioned, brainstem, internal capsule. We routinely monitor also aneurysm clipping surgeries as well, especially the anterior circulation aneurysm. If the students remember the circle of Willis, mostly we monitor MC and AC aneurysms. Epilepsy surgeries we do frequently. Then we do movement disorder surgeries here. The Neuro Electrophysiology is also used in our setup in complex neuroradiology procedures. For example, big aneurysms, and they're going for coiling. Recently, we had a big aneurysm, about 35 millimeter of internal carotid artery, and we planned balloon occlusion by the neuroradiologist. So we were monitoring that, and all of these surgeries in NNI KFMC are being monitored. Of course, these surgeries I'll pass on to the next one. Okay, so for students, before we get to modalities, 2 things you need to remember. One is, whenever you want to stimulate certain area, you remember, just think of the whole central nervous system and peripheral nervous system. You stimulate a particular area and you record a particular area. So for example, if you want to identify the sensory status, you obviously know that the sensory pathways are ascending pathways, so they are going towards the brain. So just build up a concept today, where this is your take-home message, especially for students or younger surgeons who do not have much idea about it. If you want to identify the sensory system, you stimulate the peripheral nerve and you record in the central nervous system, you can go up to brain, you record from the brain. So I hope you understand that. There are two important concepts in neuro-electrophysiology: stimulation and recording. You stimulate, obviously you stimulate for a sensory system. If you want to identify a sensory system, you stimulate in the periphery and you record centrally. And then if you are recording a motor system, you know that the motor system are descending pathways. So you have to stimulate the brain directly or a motor area, and you record as the signals come down. I'll get to the next part. The parameters, the stimulation parameters and recording parameters, so you don't have to go into those details. This is a very technical thing, and I'll leave it for some other talks. Okay, so two concepts. As I told you, you remember stimulation and recording parameters, stimulation and recording. Then remember these two special, you can say, names, or you can say these two terminologies that are very important before we get to our videos and animations. Mapping. You would frequently see brain mapping. You would hear about brain mapping in electrophysiology. Mapping is something where you do not know what is underneath. Wherever the surgeon is working, for example, say he's working on brainstem, he does not know how far away he is from the facial nerve nucleus or facial nerve, let's say. We identify it by stimulating, by giving him an electrical stimulator, and he puts that stimulator on the tumor, and we sense the current. And the current goes to the nearest neurological structure, and that neurological structure gets activated. And you know the concept of CMAPs, the current conduction happens, and whichever the nearest structure gets stimulated, for example, the current reaches the facial nerve. The facial nerve, then you know that facial nerve is going to go to face muscles. You know those muscles, orbicularis oculi, mentalis. You put needles on those muscles and you record a CMAP, a muscle action potential from those muscles. So in that way, you actually identify that particular structure. So I hope you get my point, that mapping is something where you identify in a structure. You have the sort of sense of it, but you do not know for sure, because you know in brain, the tiny little millimeters, they are very important. You cannot just disregard that. And they may result in injury if you take them out without actually knowing them. So mapping is a technique where you identify something in the central nervous system or even in the peripheral nervous system, and you identify by using giving currents, and the current spreads and the current hits whatever the neural structure nearby. That neural structure fires, and you record. Knowing your anatomy, you record from the relevant receiving structure. For example, as I mentioned, in facial nerve, you record from facial muscles. Then monitoring. Monitoring is basically where you know that there are systems, established systems, as I discussed, sensory system, motor system. You know those systems. You monitor the real-time functions of those systems by stimulating a certain area, recording a certain area. So there you know that system exists. You're just monitoring the function. So mapping identifies something, and monitoring gives you the real-time function of that particular mapped structure or identified structure. Okay, so let me show you the first animation that I've made for you. This is the most important actually no, I'll get to that part. Just to give you the mapping idea, so see, you can see that this is the diagram of brainstem, you can see that, and I'll just quickly move on. If you see this is on the left side, the blue color structure. If you see these things, this is the monopolar stimulator. It is a conducting, you can say a conducting electrode, and the surgeon holds this thing, and he stimulates the tumor. He does not know how far he is from, say, a facial nerve or trigeminal nerve, for example, and the current spreads, as you can see with these blue current marks that I've put them on this diagram. And what happens is, in the next slide, you see this is facial nerve nucleus. You assume that, you know this by anatomy, but you're not sure. So what happens is, you see, John, can you see those yellow waves forming on the face?
Yeah, yes, I can. Let me get muted. I'm muted. Yeah, I can.
Okay, so what I'm trying to suggest to our students is, so once the current hits this facial nucleus, this facial nucleus gets excited or stimulated, and this nucleus through the facial nerve sends this current to the facial muscles, and there I have very tiny needles placed on the face, and those needles are then recording these synapses in terms of, you can see these waves, and these waves are recorded, and then I tell the surgeon that likely you are hitting the facial nucleus. Similarly, trigeminal nucleus, when this gets stimulated, the nucleus sends the current to trigeminal nerve. Through the trigeminal nerve, it goes to, if you can see the next wave that is coming up in blue, that is, I'm recording from masseter muscle. As we know that masseter is the muscle supplied by trigeminal nerve. So the important thing here, there are a couple of technical things, but I don't want students to be confused by that. I just want them to understand that what is mapping, you identify the nucleus by giving a current over the tumor. So imagine that this nucleus was not visible actually, because there was a tumor sitting on top of that. So once you give the current on the tumor through that conducting electrode, the current spreads, it hits the nucleus, whichever nucleus it hits, it goes from the nucleus to the nerve, relevant nerve, and then from the relevant nerve to the relevant muscle, and we record synapse from the relevant muscle. So this is how the concept of mapping was established. Let me give you an example. I don't know whether there are residents logged in. You've got brainstem epidermoid on the left side. You see this, this tumor is located. This is on the left is a pre-op, the right is a post-op. Let me show you the video. See the video? Can everybody see the video?
Yes, we can.
Okay, so this is the surgery from our own patient. As you can see, the surgeon, he's removing, you can see this is the probe. You see, this is the probe. He's probably stimulating the, I think this is facial nerve, but he does not know. And you see, this is on the left side, this is trigeminal nerve. He's stimulating, this is the probe he's holding up. This is the conductor. Through this, when he touches the nerve, I give current, a particular parameter, and then the current stimulates that particular nerve, and we record using our knowledge of anatomy. And there are other things, the parameters, I'm not going to go into those details, just for students to understand that how this concept is done. You see, this is the probe. The trigeminal nerve is clearly exposed, and then we can even identify even tiny branches of trigeminal nerves. This patient actually, if people have any interest, this patient presented, if he was a young patient, presented with severe trigeminal neuralgia, that was not responsive to even 5 medications. So this patient was brought in for, then eventually on the MRI, we identified the tumor. You can see, this is the probe. This is, again, the probe. Our surgeon, he really believes in that, and whatever current that you see, this nerve has been compressed here. The vessels are clearly identified. I'm not going to go into those details of anatomy because people would understand. So this is how, those nerves are identified, mapped. And not only that, during tumor removal, what happens is that whatever the intensity of current we gave to that nerve before he started tumor removal, we want to make sure that during tumor removal or after the tumor removal, we do not have to increase that intensity. And we keep stimulating, as you saw that in the video, the surgeon kept stimulating. And in that way, we knew that whether we had to increase the intensity, if we are increasing that intensity, we know that we are probably damaging the nerve, and that may result in transient deficits. So whatever the intensity, a healthy cranial nerve, for example, in this case, facial or trigeminal nerve, they normally produce a response under 1 milliampere on a very small duration current. There is a thing that we call pulse duration of current. We do not give constantly this current. When you saw the surgeon touching the nerve, we were not constantly giving the current. We were just giving one pulse of 100 microsecond or 150 microsecond pulse. So you can imagine a microsecond pulse, very small duration pulse on a very small current, less than 1 milliampere. That nerve fires, that sends signals to the face muscle. We record from that, and based on whether we recorded from orbicularis oculi, we know that this is facial nerve. If we recorded from masseter, we know it's trigeminal nerve. I hope you understood that. This is the concept of mapping. Let's go on. Let me show you actually, we talked about EMGs. If you see this picture on this left-hand side box, this is the EMG screen. And if you see on this left side picture, on the left of this left side picture are left side body muscles. If you see, it says L mass on the left, extreme left, in pink, L masseter muscle. This is the EMG I'm recording. This is spontaneous EMG I'm recording. If you see below that, it says LOCCU. It's left orbicularis oculi, similarly mentalis, trapezius, and you see all those muscles down there. You see those, the irritation happening in the nerve on the right side. This is how the irritation looks like. Now, if you see, this is left oculi on the left. This purple one, or you can say bluish purple one on the right, is the right oculi. This is when the surgeon is poking around the facial nerve. I see this irritation coming up in my EMG test, and I tell the surgeon that this irritation is happening, and you have to proceed with caution. If this exacerbates, this may result in motor weakness post-op. So in that way, in real time, we identify and we tell the surgeon that this is happening. If you see on the right-hand side of this screen, this right-hand side square box, if you see the second muscle, it's ROCCU. You see this is now quiet. Means the nerve is now not irritable. It's quiet, and this is how the surgeon proceeds during such surgeries. That may be more complicated. Just to give you more idea about more help that we provide to the surgeon, you can see the left side there is a tumor. It's on upper cervical area, just below, or actually you can say just below brainstem, upper cervical C1, C2 area. This is on the left is the tumor, the right is post-op. Let me tell you how we help. Now this is our own patient. You can see the surgeon. Again, you see the stimulator, and he's probably stimulating the 11th cranial nerve there. This is a C1, C2. He has done laminectomy, C1, C2 from a posterior approach, obviously. And now he's stimulating the C1 root. And I'll tell you why what we were monitoring. So you can imagine, let me stop it for a while. So if you see this one, this nerve, can you see my mouse, guys?
Yes, we can. We can see the white hand.
Okay. Yes, the white hand. You see this? This is likely the 11th cranial nerve. So he stimulated that just to identify. Although experienced surgeons would know it, but just for the sake of students, I brought this video. They can understand that this is the 11th nerve. How we identified it? We mapped it. How we mapped it? We gave the stimulator to the surgeon. He touched that nerve. I gave a little bit of current, and we know that 11th cranial nerve supplies trapezius. So I have needles placed on trapezius, and I record C-map, and we stimulate the nerve. And I'll show you in my next picture. These C-maps are recorded from trapezius. And then you see he's stimulating C1, C2 here. And I was recording from diaphragm. You know very well that the diaphragm origin is from phrenic nerve, exits through C1, C2, and maybe sometimes even C3. And you record from there. So you want to make sure the diaphragm was good. I'll move on to the surgery. We also did spinal cord mapping here. Let me tell you what is that. Here is the cord, proximal cord. If on the hand you see this is the distal cord. He stimulated the proximal cord, sends the signals down distally, and we recorded from the muscle. Then below the tumor, distally, he stimulated the cord, and we want to make sure that we're not pushing too much, putting too much of pressure on the cord. So we sort of did spinal cord mapping. We stimulated the cord, recorded from muscle. I know it's going to be a lot of things maybe for students. For surgeons, probably they would understand more. But students, they may be a little too much of information. But I'll try to give, that's why I brought videos for them to understand. See this, he's now stimulating the cord here. And this, his stimulator is now, this is probably the cord proximal to the tumor. And we stimulated the cord to see how good the cord is. This patient was he had hyperesis. Now he's working on the tumor. You can see this. It's trying to make sure all the nerves are clear. Excuse me. So while he's removing this tumor, I'm constantly doing two tests: somatosensory evoked potentials and transcranial motor evoked potentials, and I'll get to those tests in my probably next couple of screens. You see this after the tumor is removed, he's again stimulating the cord just to see that how the signals have changed, if at all, during the surgery. And of course, we do this, and he's now touching these roots as well, just to identify that everything is the same. How we know that? By giving the same intensity current post-op. This is how when I was telling you about, if you can see this picture, this is the right. I'm looking at on my left side box. If you see this mouse moving, if you see it says the big C map here, it says RTPZ. If you look closely, it's right trapezius. So when he stimulated that 11th nerve, this is the wave I got on trapezius. That's how we identified that it was trapezius. And you can see this, a diaphragm also somehow produced this right picture, the top one, the small wave. That's the wave that was recorded from diaphragm to identify the phrenic nerve or the C1, C2 nerve. Okay, so just to give you a crux, this is how a screen looks. I'm sure the students may have gone through rotations in neurology, and they may have seen EEGs. So this is, EEG is one test. In intra-operative electrophysiology, we do multiple tests in one patient. Tests like somatosensory evoked potentials, we do transcranial motor evoked potentials, and depending on the tumor, if it's a spinal cord tumor, we do spinal cord mapping, we do direct waves, we do EMGs. So multiple tests in real time, then only I gather the information. I just don't see one test and tell the surgeon, oh, you know what, this is what it is. Historically, the first test that was brought into the OR was somatosensory evoked potentials. To you, we stimulate a peripheral nerve and we record from the brain. This test was introduced in the spine OR, in spine surgery OR, especially in tumors and scoliosis or deformity patients. And they thought that if they do spinal cord, if they do somatosensory evoked potentials in those patients, and if the somatosensory evoked potential stays good throughout the surgery with no changes, and I'll tell you what changes we're talking about, they would think that the spinal cord integrity has not been damaged and there should not be any post-operative issues. But they continue doing the somatosensory evoked potentials, but then they realize that the patient with intact somatosensory or no change somatosensory evoked potentials during the surgery, they presented post-op with motor deficits. So they realized that the somatosensory evoked potentials are not enough because they're not predicting motor deficits. So then the concept of transcranial motor evoked potentials came in. So now all patients, in all my patients, I do not believe in only SSEPs or somatosensory evoked potentials. In all my patients, regardless of pathology in brain, spine, I do both SSEPs and motor evoked potential, and this is pretty much a screen. And it's a pretty complex screen, a lot of information. That's why it's a subspecialty now in the US. The intra-operative electrophysiology is sort of a very rewarding field right now, actually. But let's go to the next screen. If you see this video, this is my screen. If you see, I know it's a little blur, but while the surgeon is removing the tumor, this is in the spinal cord. But if you see, this is a screen in the bottom. It has this test on the left. This is upper somatosensory, right upper somatosensory, left lower somatosensory, right lower EMGs, motors, left side motors of body, right side motors, and I even monitored EEGs just to see how changes in anesthesia are affecting the signals. So you can see it's a very complex screen. I do not want the students to be worried too much about it. The take-home message was to understand monitoring and mapping. And then the next few slides would be their take-home message. Before I get to that slide, everybody, I hope understand the Penfield homunculus. We know that the parietal lobe, the postcentral gyrus is the primary sensory cortex, and the precentral gyrus is the primary motor cortex. Just to having this in mind, let's move on to our first test. This is the take-home message. The next few slides are my animations that I've made, and this is the take-home message for students. What is transcranial motor evoked potentials? And for junior residents or neurosurgeons, if they are logged in, 15 to 20% of Saudi neurosurgery and spine surgery boards, they have questions about Neuro Electrophysiology. Give you more information, 20% of Saudi anesthesia boards, anesthesiology boards, they have questions about Neuro Electrophysiology. Also in the US, a significant number of questions are being asked about Neuro Electrophysiology in neurology boards, neurophysiology, spine surgery, and neurosurgery boards. So, you need to understand this. If you want to be a neurosurgeon or spine surgeon, you need to understand these modalities. And this is the time I can give you a very good animation. So let's see what is transcranial motor evoked potentials. Now remember, the way I teach students is read the name, transcranial. So basically and it's motors. Remember I told you in the beginning that there are two ways you need to do things. One is the stimulation site, one is the recording site in neurophysiology. Everywhere, all those tests that we do, we have some sort of this stimulation and recording. And as you remember, do you guys hear music? John, can you hear music? Oh, okay. Let me actually turn the music off.
Yeah, okay. I thought that was coming from one of the panelists.
Oh, no, I thought people would not sleep. That's why I brought some music, but hopefully people are staying up.
Okay.
Okay. All right, so transcranial motor evoked potentials. Just focus on the name, transcranial. So basically, it's a motor test. So we're going to stimulate the cranium, the scalp, and we're going to place our stimulators, our electrodes, and I'll show you how. And in my next slide, so imagine this is your patient. So what happens is, if you see these two electrodes on the right side, and we call them corkscrew electrodes. I use them in all my cases. This is my stimulation electrode. Remember, this is a motor test, so my stimulation is going to be in the central nervous system. So I'm stimulating the scalp. And what happens is that this stimulation, after this, these green lines, I hope you just saw that, these are my recording sites. These are EMG needles that I place on these muscles. You can place those needles on any muscle. You can place it on face muscle, you can place on trapezius, you see here on my arrow, you can place on deltoid, biceps, whatever, you name it. You can place in lower limb muscles, depending on the surgery, of course. So say, for example, the surgery is happening in cervical spine, you know that you have to place those electrodes, recording electrodes on both upper limbs and lower limbs. So what happens in transcranial motor evoked potentials? You place electrodes on the scalp based on the homunculus that you remember, and there is a way to get into those details. I do not have time to get into those details, but if you remember that homunculus, ideally you following a 10-20 system, what we call it. Those people who have done neurology rotations and they have seen EEGs, they may have seen how 10-20 system works. Maybe on another talk I can briefly describe it to them. So we place those electrodes on the scalp, assuming on top of the motor cortex, and then we give current. So if you see these red marks now, if you see these red lines, this is the current flowing down. As the current flows down, wherever it reaches, we have needles there, and those needles record the CMAP, the compound muscle action potential. I'm not going to go into the basic physiology. I hope students, I'm assuming they have read the physiology part of how muscle action potentials are formed. What I'm trying to show you is a very important test, transcranial motor evoked potential. You stimulate the scalp, you record as the signals go down. I'm just giving you a few examples, few muscles. You can record anywhere, depending on the surgery. Say, for example, if you have a thoracic spinal cord tumor, you should not be too much worried about upper limb. So I hope you are with me, guys. So if it's a tumor in the thoracic cord, you're basically concerned about lower limb. So I place more like 2-3 muscles in the lower limb, or even anal sphincters. You can monitor genital functions as well. And then upper limb would just be acting as a control, just to see what's going on in the upper limb and any changes, systemic changes that may be affecting the patient. So I hope you understood transcranial motor evoked potential. You stimulate scalp using certain electrodes. Through the scalp, the current reaches the dura, through the dura into the motor cortex. Motor cortex gets stimulated, and then the whole conduction begins from corticospinal tracts all the way down to muscle. Depending on which muscle you want to record, you place needles there, and you record from those needles as CMAPs. And now, this test is very sensitive. Any change due to ischemia or due to blood loss, the same thing, or due to even direct injury to the fibers, the corticospinal fiber, say, for example, in the brain case. I'll show you the next video. how these changes are interpreted. I hope you understood that. So now let me show you how the signals look like on the screen. If you see, just look at these right four screens, the right four pictures. Forget about the left side for a moment. If you see these left side screen, the left top one, you see many waves. If you see the first one, it says left APB, abductor pollicis brevis. Basically, it's a left upper limb signal. And then I have two URAB, which is just my labeling. You can label anything you want to label. It means URAB means rectus abdominis. And then I have lower limb muscles as QUAD. You can see quads. TA means tibialis anterior. EHL as extensor hallucis longus. Gastrocnemius as GAS. So this is the baseline. This is the left side motor evoked potential. So what I've done here is I stimulated the right side brain and I recorded from all these left side muscles. All these muscles had needles on them and I recorded these waves. This is the right side, same thing. But here I stimulated the left brain, as you can imagine, because there is decussation at the brainstem. So I'm stimulating the left brain, recording from right side of the body. And this is how the signals look like. And then see this now, the bottom, the second left picture, you see this, there's a flattening of waves. You see this drop? Can people see that? Hira, can you see that? Hello?
Yes,
Yes,
yes, we can.
Hello? Yeah, so if you see this, if you compare this flattening or, decrease in the amplitude of those waves or the polarity, the way the waves look like, if you see and you compare it from the top one, you see there is a drop. But if you see on the second bottom picture, if you see the APB is intact, the APB signal, which I told you is the upper limb, abductor pollicis brevis. This is a scoliosis patient undergoing thoracolumbar scoliosis. And you see this upper limb is intact, and the lower limb on the left side has completely, you can say, severe deterioration of signals. I understood that. I immediately saw that. I told the surgeon that this is screw that you're placing. He was placing, I think, one of the mid-thoracic on the thoracic side, of course, on the left side. And that resulted in this change. I immediately notified it, and the surgeon removed the screw. How I was sure that it was not because of anesthesia, because you see the upper limbs are intact, the upper limbs are good. So imagine if this was because of a systemic event or a significant bleeding event in the body, upper limbs should have also dropped. But if you see the left upper limbs are all good, only the lower limbs are dropping. So this is how we see the motor changes, and we identify it and we tell the surgeon immediately. I hope you guys understood that. Let's move on to the next one. Somatosensory evoked potentials. Sorry, music. Let me just turn it off. Okay, so somatosensory evoked potentials. What are somatosensory evoked potentials? Again, as I told you, focus on the name, somatosensory evoked potentials. You're going to produce a response. You're going to trigger a response, create a response. And of course, it has to be a sensory response. So you know that the sensory system is an ascending system. And if you are doing a somatosensory test in the upper limb, you're going to stimulate in the upper limb. Remember, in motors, we stimulated the scalp and recorded from the muscles. In SSEPs, we stimulate a nerve in the periphery and we record as the signals go up. So let me show you in the animation. If you see this, the same thing is happening here. But now our stimulation is the nerve. It's not the scalp. It's the nerve. If you see, I don't know, I hope you people can see these red lines coming up. Can you see that?
Yes, we can.
Yes.
Okay, so these red lines is the current going up. And this is on the wrist, I have stimulation electrode. And this is stimulation electrode on, for example, my mouse is on the right median nerve or right wrist, where on the wrist I have placed electrodes. And these electrodes I'm going to give currents to them. And this current is going to go up. I can record even at cubital fossa, here. I can record at brachial plexus. I can record at brainstem, and then I can record at the somatosensory cortex. I hope people understand that the somatosensory pathway, the dorsal column pathway, this is exactly, I'm following that dorsal column pathway. So for example, now imagine this SSEP, upper SSEP, imagine the surgeries on brainstem area, for example. Here, where this decussation is happening, where my mouse is, So for example, and now I'm doing this SSEP. What we do actually in all intraoperative monitoring cases, we get baselines before the surgeon does anything. After positioning of the patient, we get baselines. Baselines mean we stimulate transcranial motor evoked potentials, see how the signals are. We stimulate somatosensory evoked potentials and see how signals are. And this becomes our baseline. We do not compare that baseline to outside published data. That particular data of that particular patient on the day of the surgery is what we want to keep till the end of surgery. We're not worried about, of course, we can identify whether the patient has deficits and all of those things. But our aim is to keep that data, which is before incision, till the end of the surgery when closure happens. So imagine if there's a brainstem tumor. All these numbers are important. So see when for example, the first wave you see on the right hand is 9 ms. Ms is millisecond. Normally in an adult man or a woman, when you stimulate the median nerve at the wrist, it takes about 9 milliseconds for signals to reach brachial plexus. Then it takes about 13 milliseconds, so meaning 4 more milliseconds to reach brainstem. And then on the contralateral somatosensory cortex, it takes about 20 milliseconds from wrist to somatosensory cortex. Now, before incision, we got these numbers. We got on the left and right side. So say, for example, the tumor was on the brainstem here. This 9 milliseconds should not be affected. I hope you guys are with me. This from stimulating the wrist to brachial plexus should not be affected. But the second and third waves may be delayed, or they may lose their configuration, or you can say their morphology, or you can say their shape. I hope you guys are with me. When this happens, I tell the surgeon that this is something happening. We don't wait for drastic changes. We immediately try to see if there is a decrease in conduction, meaning this 13 milliseconds is now during surgery becoming 14. This wave is now coming at 14 or 15 milliseconds. And then, of course, similarly, the wave on the brain, on the somatosensory cortex is also increasing in time. So we tell the surgeon that there is some kind of deterioration happening. Normally, we identify changes in terms of percentage. So say, for example, whatever the shape, whatever the morphology of this wave was before incision, if this drops to 50%, that tells us that there is a significant change happened, and this patient may have post-operative posterior column or dorsal column issues on that particular hand. I hope you guys understood. Hira, did you understand that?
Yeah, I did.
Okay, so I know that's a little bit too much because I did not understand that when I was reading it for the first time. But if you guys are able to do that, that'll be nice. So now let's move on to the lower limb. The same. Let me turn off the music again. Sorry, guys, for this. Oops. Okay. Lower limb, music down. Okay, so in the lower limb, same things. We stimulate. Remember, for students and young surgeons, the take-home message is these two tests: somatosensory evoked potentials, motor evoked potentials, or transcranial motor evoked potentials. If you understand that, of course, there are minor details, the parameters, how much stimulation, what frequency setting, all of those things are sort of technical. I'm giving you a clinical perspective. Now, lower limb somatosensory evoked potentials, how we do that? Again, it's a somatosensory test. So we have to send the current up. Remember, I told you two things: stimulation point, recording point. In somatosensory, stimulation point would be a peripheral nerve. So in a lower limb case, you normally use posterior tibial nerve. You can use a common peroneal nerve. You can use even femoral nerve. In one of our patients, the leg was amputated from the knee. So there was no ankle available for me or the leg available for me. And it was a scoliosis patient. So I did, it was something on the thoracic area. So it was a spine, thoracic spine patient. So I stimulated the femoral nerve and I sent the current up through the femoral nerve to the brain. And, so you can imagine what we're trying to identify here is in spine surgeries, if something happening in thoracic or thoracolumbar area, these signals would get obliterated or they would decrease or they would deteriorate, and we tell the surgeons based on that. Again, in this, as always in IOM, we get a baseline before the surgery, and whatever the numbers are, whatever the morphology or the size of the wave, we call them amplitude. Amplitude is the size of the wave, and then the latency is the time it takes for the wave to from one point to the other point. So you can see, if somebody asks you, for example, what is the latency that a healthy adult man, when you stimulate posterior tibial nerve, how long it takes for the signal to reach brain, you tell them, in a healthy adult one, it takes about approximately 37 milliseconds. MS is again milliseconds. So, and then you can see this, the first wave on the middle in the thoracic cord, as the signals reach the cord, it normally, if the patient does not have any diabetes or neuropathies or other neurological disorders, normally it takes about 21 milliseconds to reach the cord, then about 31 milliseconds to reach the brainstem, and then 37 milliseconds to reach the somatosensory cortex. So you can imagine whatever baseline I have, when the surgeon is working on the thoracic spine or even in the brain, I see these numbers, I see these waves. So I look for both those two changes, which I just mentioned. Amplitude, which is the size of the wave. Any drop in that amplitude from baseline, meaning before incision data, is compared. And if there is a pattern developing of drop, I tell the surgeon. And or if there is an increase in timing, now it's taking, instead of 37, it's taking 39 or 41 or whatever it is. Normally a 10% increase is considered significant. So I tell the surgeon that something is happening. And of course, if it's a bilateral change, we know that this is because of a central issue. And then if it's a unilateral change, it can be because one leg is not getting enough perfusion, or maybe the surgeon is working on one side and there may be a damage there. So I hope you guys understood that. TCMEPs and SSEPs. Just understand the basic phenomenon behind that. I'll move on to the to show you an example of how SSEP change is identified. You can see this MRI. It's a tumor going up to the fourth ventricle. On the right side of the picture, you can see there's a big syrinx as well. I'll show you what happens, what we did during the surgery as a video. You guys see that? Can you guys see those pictures?
Yes.
Okay.
Yes.
So imagine this one. Remember, all IOM cases, all Neuro Electrophysiology cases, as I mentioned, we must have SSEPs and TCMEPs. And then based on the pathology and the area of the pathology, we add other modalities like EMGs, spinal cord mapping, brain mapping, which we'll get to that later. Now let me show you how we identified a change. Now, this is the same tumor. As you can see, this is the dura has been opened and secured. This is an intramedullary tumor. We are opening, and this is the myelotomy where we have opened the cord. While he has opened the cord, I'm constantly doing SSEPs and TCMEPs. Now, let me show you what happens. I'm just giving you this video for you to have a proper comprehension of what exactly I'm talking about. You see this, he's doing the mapping, he's stimulating the cord, and he's trying to see what's going on in the cord. It was a big tumor, so we did the first myelotomy here. Now he's doing the second myelotomy. These are our own patients. And I like to keep certain videos because we have very nice ORs and very nice screens, and the microscope gets these recorded, and I then bring them to my computer, and then I make those clips. So you can see this was a big ependymoma, and he's removing the tumor. Now, can anybody amongst the students tell me that he's working on this posterior side of the cord, what signals he would be expecting to drop? If you know the anatomy of the two tests that I just told you.
Sensory.
Sensory, exactly right, because the dorsal columns are going over this posterior part of the cord. So that's exactly what I would just show you, if you guys understood that. Although the surgeon tried to do the midline incision, which is the surgical technique, I hope when you grow up and you go to more surgical training, you would know that. We can even identify that, but I'm just giving you a baseline, just like a minimum possible idea of what happens. So you can imagine that sensories may be dropping, but even motors can drop. the tumor may be impinging on the ventral cord as well. So we look for both sensories and motors. Let me show you how this is post-op. Let me show you how the signals drop look like. You can see this. Can you see this picture? The red line, the red circle that's just came up, or red, you can say whatever, oval shape signal. You see this green line, very poor signal. This is the right side median nerve upper limb. So you can imagine the tumor was on the neck. The right side, this green line is the baseline. If you see this wave, this is the wave which I recorded from brain stimulating the right median nerve. If you see these purple and black line, you see this poor, although the pattern was already very poor, it's deteriorating. If you can compare this shape has been lost. But if you compare it on the left side, you see the left side green line just next to that picture. You see the left side green line. It's much bigger morphology, and it's keeping that morphology, although there's a small drop there too, but it's keeping that morphology. But right side has completely lost it. I told the surgeon that I'm losing right side somatosensory evoked potentials, and normally what the surgeon would ask me next, how about motors? So if you see this now, look at the right of the screen, the two windows on the right of the screen. If you see, my arrow is right now on the right motors, right body. This is where I'm stimulating left brain and recording from right side of the body. And this is I'm stimulating right brain, recording from left side of the body. These signals stayed intact. Only this dropped. As long as motors are not dropping, surgeons are generally not worried in intramedullary tumors, because their aim is to do a total resection. So I told them that the sensories are dropping only in upper limb, one side, and he told me that, okay, I'll take it. I'll continue removing the tumor. And he continued removing the tumor. Motors did not drop, and we came out with a very successful surgery. This gives surgeons assurance. This is very, very good information. And he has this confidence that, okay, I'm not damaging the cord, my motor power, the patient will wake up with motors intact. So, he has more assurance, and he does comprehensive surgery. So do we have more time? I want to share these few more animations. Or guys, this is too much information already?
Yes, we do have more time.
Okay, all right. So this is a very important thing, and I've made it very simple. Now imagine you understood the two tests. You understood actually 3-4 things that I can just repeat. I talked about stimulation points and recording points based on which test. Sensory test, stimulation point would be periphery, recording in the central. Motor test, stimulation point would be scalp or brain or proximal, and then we record distally because motor pathways are descending pathways. Then I also told you about mapping and monitoring. Mapping is when you identify a particular structure which you know but you're not sure and has been obliterated by the pathology, by the injury, by the tumor. And monitoring is when you know the system and you are just monitoring the function of that system. So SSEP and TCMEPs are monitoring techniques. I hope you guys are with me. We already know that there is a sensory system. We already know there is a motor system. We're just trying to stimulate certain things and record from certain areas to see this is the monitoring part. Now I'm going to show you a little bit of mapping part. I'll just turn the music down again. Okay, so this test, trust me, I understood this part much later, but I've made this simple. These are my own animations. I've made them. So let me show you what happens. What is the use of this? This is the same thing, primary sensory cortex mapping or central sulcus mapping or phase reversal. I'll tell you, wherever you see these names or these things, central sulcus mapping is the same as primary sensory cortex mapping. And when the surgeons talk about phase reversal mapping, they're talking about primary sensory cortex mapping. So understand this part. In our surgery board that held recently, they ask specific questions about sensory and motor cortex mapping, and I'm going to explain this to you. As a surgeon, it will be nice if you can remember them. Okay, so what happens is, what is the need of this? So by mapping, I mean that you do not know where the sensory cortex is. I'm talking about primary sensory cortex mapping. Remember, I told you that pay attention to the word, what I have written, primary sensory cortex mapping. So mapping means you identify primary sensory cortex. When do you feel the need to identify that? When the tumor has obliterated the sensory cortex. So let's see what happens, how we identify that. So imagine this. Can you see those white now that this brain has become white?
Yes.
Okay, so this is a tumor. I'm just assume that this is a tumor, and now surgeon has this view. Now he does not know for sure where is the central sulcus. And we know that by anatomy that the central sulcus, anterior to central sulcus is primary motor cortex, and posterior to central sulcus is primary motor cortex. How we identified that using electrophysiology, I'm going to show you. What we do here is we place, now remember the SSEP. See, since we are talking about sensory cortex mapping, so we're going to use a somatosensory evoked potential test to identify it. Does it make sense to you guys? It's common sense, right? Sensory cortex can be identified by using an SSEP test. How? Imagine this is a left brain. I'm just going to give you an example. Imagine this is the left brain and the tumor is on the left side. You know that the sensory pathway, I'm going to stimulate the right median nerve. Are you guys with me? I'm going to stimulate right median nerve, and I'm going to record on this tumor using a special electrode. Why right median nerve? Because you guys know that the decussation happens on the brainstem, and the left brain is actually receiving the right side sensory system. Everybody agrees with that?
Yes.
Right, guys?
Yes. Yeah.
Okay. So left brain, I'm going to stimulate right median nerve, and I'm going to send the signal up. There are certain parameters. I'm not going to go into those today, maybe in another lecture. And what happens here is I bring a strip. You see this strip which says 1, 2, 3, 4? This is a platinum strip. These are actually my recording electrodes. Can everybody see this strip?
Yeah.
Yes.
Okay. So what happens is, now, because you know we do not have scalp available because the surgeon has done craniotomy, there is no scalp available. So what we do is we bring in our own strip, which is a platinum electrode. You can use stainless steel. Platinum is a little expensive. These are electrodes. We give it to the surgeon, and we tell the surgeon to keep this electrode on top of the tumor. Now these electrodes, they become our recording electrode. Remember I told you in the beginning, there are stimulation sides, stimulation electrode, recording side, recording electrode. So in primary sensory cortex mapping, we're going to record on the sensory cortex. We're going to stimulate the right median nerve if it's a left brain tumor. Now what happens is, as the signals come in, let me show you how the signals get recorded and how they look like. So see these numbers. I hope can you see all these waves that are coming up as 1, 2, 3, 4?
Yes.
Okay, great.
Yeah.
So see this. Now, the important technical part here is that the sensory cortex produces a particular morphology comparing it to the motor cortex. And I'll show you, you just need to understand, and I'll make sure you leave today's lecture understanding this. So these are the two numbers. You can imagine that 1, 2 maybe is on the interior of the sulcus, maybe motor area, and 3, 4 maybe posterior of the sulcus. But I'm just giving you maybe. How we prove this? We prove this by you seeing this wave. You see there is a difference. Look at number 1. Number 1 has first deflection going down. First deflection, just follow my mouse, the arrow. First deflection going down, and then morphology appears. That's it. Number 2 also has first deflection going down, and then going up, and then the morphology follows. But if you compare these two, 1 and 2, you can see that 2 has a bigger amplitude, meaning 2 has a bigger size. Everybody agrees? The students? Right, guys?
Yes.
Yes.
Yeah. Yeah.
Okay. So now come to number 3. Number 3 has first deflection going up. You can clearly see that, right? And then
Yes.
the morphology follows. Number 4 has also first deflection going up. And probably you can appreciate that number 3 has a bigger amplitude, meaning a bigger size than number 4. Everybody agrees?
Yeah.
Yes.
Okay. So in electrophysiology, there is a little bit more into it, but I'll just make it simple for you. You see the change in, we call this shape, we call this polarity. You know, whatever shape it is coming up, number 1 and number 2 has same polarity. This downward deflection first, and then going up, and then the wave finishes. This 1 and 2 has same polarity, but little different size or little different amplitude. Number 3 and number 4 also have the same polarity, but a little difference in the amplitude. Everybody agrees?
Yes.
I'm just giving the name of polarity, a particular waveform. So every wave that is going down, I'm saying that these waves have same polarity, meaning same shape or same morphology. The other wave is going up, the other two, I'm telling you guys that I call them a different polarity because the first wave is going up. So sort of there is a change, there is a reversal in the shape. Are you guys with me?
Yes.
Okay, I thought it was, I think probably for you it's a little complicated. But so to help you understand, this first wave going down, second wave going down, third wave going up, there is a change in the wave shape now, right?
Yeah.
Right.
Okay, so between this change, between number 2 and number 3, there is the sulcus. Because the sensory system is not conducting the wave, the pattern recognition, what I call it, is not the same as motor system. You see this downward, this first deflection going up is different from the number 2 wave where the first deflection is going down. So between 2 and 3, I'll tell the surgeon that there is between 2 and 3 wave is the central sulcus. And we know that anterior to the sulcus is going to be the primary motor cortex, and posterior to the sulcus is going to be the primary sensory cortex. And we call this phase reversal. This phase of downward deflection has been reversed, and now it has become upward deflection. Are you guys with me? So this is how we understand that between these two, between number 2 and number 3, here is likely the central sulcus, because number 3 and number 4 have similar morphology, wave going up, and 1 and 2 have similar morphology, wave going down. Let me give you an exercise. Let me show you more. So I have brought another strip which has 6 electrodes now. You know the strips, they come in 4 recording electrodes, 6, 8, 10, 12. I'll show you an example of an epilepsy case where we were using 16 strip electrodes, 16 contacts. You can see there are 6 contacts on this electrode. Remember, they are on the scalp. They are recording electrodes. And remember, we are doing primary sensory cortex mapping. Let me show you the waves. You're going to tell me where is the phase reversal. Okay, you see 6 waves. Now any volunteer can tell me where is the reversal.
Between 4 and 5.
Look at the wave. Yeah, go ahead.
Between 4 and 5?
Between 4 and 5, absolutely. See, you saw that, right? So you understood that. There is a reversal. There is a difference pattern between 5 and 6, comparing it to 1 to 4. Are you guys with me?
Yes.
Yes.
Now see this, another important thing.
Yes.
So this is how we identify the sulcus, where this change in morphology happens between 4 and 5. This is how we identify that, okay, so if I'm the electrophysiologist, I'm going to tell the surgeon, down this strip, the way you have placed it, between 4 and 5, you have central sulcus. So likely 4 is the primary motor cortex, and likely 5 is the primary sensory cortex. Are you guys with me?
Yes.
Yes.
Yeah.
Okay, now also pay attention to another important thing. Guys, I'm busy. That's easy. Huh? I did not order water leaking. No. Okay, sorry guys. So important. Now you identified what is phase reversal, right? Hira and Rakesh and everybody else. Now focus on this. See the amplitude, meaning the. Sorry. See the amplitude of number 4. You see this amplitude? Now comparing it with number 3. Then compare it with number 2. Then compare it with number 1. Hira, what do you see?
It's an increasing pattern.
Yes, there's a decreasing pattern. These amplitudes are decreasing. So if when you go up, or from 1 to 4, it's increasing pattern. From 4 to 1, it's decreasing pattern. Not only you identified the central sulcus, but the way these waves are now becoming smaller, you can also tell that which point in these four, 1, 2, 3, 4, is closest to the primary motor cortex. Are you with me?
Yes.
Yes.
So the bigger wave or the biggest amplitude should be the closest to primary motor cortex. And then as you go far anterior, remember anterior. As you go more anterior to the sulcus, you see these waves are becoming smaller. So I would tell the surgeon that number one is likely not the primary motor cortex, it's probably the supplementary motor cortex or the premotor cortex. So not only that, this mapping has identified the sulcus, it has identified the primary motor cortex. It can also tell you how far are you from the primary motor cortex. You guys understand that?
Yes.
Okay, now
Yes.
same thing applies in the sensory area. Remember, this is motor. Now 5 and 6, so this is the central sulcus. If you compare wave number 5 with wave number 6, so I can tell the surgeon that the 5 has the biggest wave with a reverse morphology, and the 6 has a smaller wave, but the same morphology. So 5 and 6 both are on the sensory cortex, but 5 is probably nearer to the primary sensory cortex, and 6 is a little far. Do you guys understand that?
Yes.
I hope you did. Let me give you one more example so you can understand that, and that's your take-home message. Now I'm using 8 contact strip. This 8 contact strip is again a bigger contact strip, and there's a bigger tumor. You can imagine there's a bigger tumor. I'm just trying to teach you here. So now you need to understand, remember our topic is plane mapping, and we're trying to identify primary sensory cortex or central sulcus or phase reversal. So keep looking at the waves and you're going to tell me what's going on. Maybe Hira can tell me, or Rakesh, or anybody else there. Now tell me, where is the sulcus? Yes, where is the sulcus? Between?
Between 3 and 4.
Yes, between 3 and 4. Absolutely right. You guys understand that?
Yes.
Yes.
So see this? Now clearly you see the pattern, the morphology, the way the amplitude is deteriorating from 4 to 8. You see from 4 to 8, there is the same pattern, but smaller size, right? All those waves, first wave is going up, all the remaining waves are going down and they're decreasing in amplitude. This is how we identified that this, which one is the closest one, the biggest wave. We would tell the surgeon that this is likely the primary sensory cortex, and a 5, 6, 7, 8 are you going more posterior. Similarly, you can say that 3 is probably the most near 3, the electrode number 3 here. You see this electrode number 3 on the strip. This is probably the motor cortex, and then the 2 and 1 you are going more anterior. Did you guys understand that?
Yes.
Yes.
Okay, so you understood now how we identify the sensory cortex, or in other words, central sulcus, or in other words, phase reversal. These are the same things. When you read them, you can understand them. Now, you have identified the sensory cortex. The next thing you need to identify is on the motor cortex, you need to identify which structures are where. For example, where is face area, where is hand area, where is leg area, and so on. So the next few 3 or 4 slides, animations again, you would understand that, and that probably would end my today's lecture. Just a few more minutes, guys. So this is the phase reversal. I hope you guys understood that. So this is my again take-home message that you understood that part. Now you have already identified the sulcus. Okay, you have already identified the sulcus. You know where is primary motor cortex. You know where is primary sensory cortex. Now, this is how the waves look like actually. Now, Hira, look at these waves and tell me. Now, this is the case that I did actually. This is an epilepsy patient. We were monitoring for ECOG. There is another test. I'm not going to go into that. But because the epileptic focus was close to the sensory cortex. Hira, can you tell me where do you see phase reversal?
Between the
closely.
5th and 6th. It's between 6 and 7.
Absolutely. 1, 2, 3, 4, 5. Perfect. Yes, very good. See this? So this is between 6 and 7. So all the 6. Now important part here is all these deflections are up. Right?
Yeah. Yes.
So all these up deflections are sensory areas. So the way the surgeon has placed the strip, the first 6 waves are all in the sensory area. Probably the 6th one is the sensory cortex. And the 7th wave is the deflection, and that is the motor area. You understood that?
All right. Yes.
Rakesh, did you understand that?
Yes, I got it.
Okay, so now let's move on. Now you have identified the sensory cortex, the central sulcus, and presumably you know that where is the motor cortex. We know in this screen, in this picture, the wave number 7 is the primary motor cortex, because that's the first wave after the phase reversal, anteriorly. So now I'm going to show you I'm going to skip those things. Now I'm going to show you how we map on the motor cortex, where is hand, where is face, where is leg. And this is just going to be animations again. Now you already have an idea. Sorry?
If before proceeding, just one small question before you proceed to the mapping.
Yeah?
If there's a difference between fifth and sixth, the amplitudes are not same. Is it important to have the same amplitudes when we have a phase reversal? Because both will be corresponding to.
See, let me tell you this.
Yeah.
What I showed you in the clear animations, not always you would get those wonderful neat and clean waves. Sometimes we receive tumors where the tumor has already obliterated the pathway, already eaten up the sensory cortex. I actually did not include, actually I included that, but I removed it just to avoid any confusion. So not always you would get the classical wave, big giant wave, and the other wave is very strong motor or sensory wave. So what I'm trying to tell you is just understand the concept, and depending on the pathology, say for example, the tumor was already operated elsewhere and now it has come to you, you're the surgeon, already the patient has scar tissue, the tumor has very bad, already patient has deficits, then you would expect the waves to be poorer. Then experience comes in, and then you have to really pay attention to get those waves, and then to see how the phase reversal is showing up, and then this is how you're going to help the surgeon. You understand that?
Yes.
So the real patient, the animations were, of course, I made them, but this is the real patient. You see these waves are still, you can recognize them. Sometimes you can even see words, but just understand the pattern. The first wave going up, likely you are in the sensory area. The first wave going down, likely you are in the motor area. Got it?
Yes.
Yes.
Okay, so let's go to motor cortex. Now you know where is motor cortex. Now we're going to identify which areas are hand areas, which areas are leg or face areas. Now, before that, you already know the homunculus. You know, in the homunculus, the Penfield homunculus, you know that the face and arm are more lateral and lower limbs are more medial. Are you guys with me?
Yes.
Okay, so it's very important that you communicate to the surgeon. The same strip, you can use the same strip that you just see now, the 4 contact strip or 6 or 8 contact strip, or you can use a bipolar stimulator or monopolar stimulator as you like it. I'm just trying for the student's sake and making it simple. I'm keeping them simple, and I'm going to tell you, sorry, there's music again here, so I can just turn the music off. All right. I hope you people are not sleeping.
No.
Okay. All right. So primary motor cortex. So in that, you can remember, always you first need to do primary sensory cortex mapping. Identify the sulcus and phase reversal first, then go for motor cortex mapping. This is my method, and a lot of people follow that. Don't go for directly just motor area stimulation. Now remember, in that primary sensory cortex mapping, you were recording on the brain. Remember? You were recording. The stimulation was right median nerve. Are you guys with me? Because you're trying to identify the central sulcus or the sensory cortex. Now, we have identified that point number, say, 4 or 3 or 2 is motor area. Now we're going to stimulate the brain. because as I told you, in motor area, you have to stimulate and record in the muscles, send the signals down, and in sensory mapping, you stimulate in the peripheral nerve and you record as the signals come to primary sensory cortex. Now, so imagine now we already know where is the primary motor cortex, but we do not know where on the motor cortex is hand, face, and leg. Remember, always talk to the surgeon. Give them the strip, you give him the strip, and say, for example, point number 1. I'm going to connect this point number 1 to my motor box. You know, there is a wire that comes out and that I connect it to my machine. So I will talk to the surgeon, which area you want to stimulate. He tells me, I want to stimulate the more lateral area. Okay, so I know that he's there on point number 1. And I know by anatomy, lateral on the homunculus is probably the face area. So I must be recording from face. So I should have muscles, Hildy needles on face. Are you guys with me?
Yes.
Yes. Yes.
Yes.
So and now I'm stimulating. You already know primary motor cortex. Now I'm trying to identify the individual points, individual motor areas for face, arm, and leg. Okay? So for that purpose, talking to the surgeon is very important. Communication is very important. He tells you that, Mohammed, I want to stimulate the more lateral, the number one contact electrode. So I'm going to tell him, okay, where is number 1? Is it medial or lateral? He tells me the way he has placed it, number 1 is more lateral. So I know by homunculus that, okay, I should be looking at face and arm. So he stimulates this area, and I record from face. If I get the face muscle response, the synapse, I tell the surgeon that, okay, this is the primary face area. Even I can even tell him that this is the primary, say, masseter area, or the muscles of mastication are there. Or I can even tell him that this is the, you know, the orbicularis oris, where the smile, you can say, or the, you know, you can even individually identify. The important thing here is a criteria, how you stimulate, how much current can you give, how much pulse width can you give. Those are important points. But if you want to remember, a healthy, if you are on the primary motor cortex, if you have done correct mapping of sensory area and phase reversal, and based on phase reversal, you have placed the strip to the motor area now, and then based on that, you're stimulating the most lateral area. And normally, a healthy brain, 2 milliampere current, 3 milliampere current, 4 milliampere current would fire the gray matter on the motor cortex, and then eventually the current moves down through cortical bulbar tracts to the face areas, and you can record there. If you are higher than 20 milliampere current, you're likely not on the motor area. But some studies even reporting that they are even going to 25, 30 milliampere. But what I do is normally I start with 2 milliampere. Say, for example, the point number 1, I'll give 2 milliampere current to that particular point and see what happens. If I do not get a response, I go to 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, up to 20. If I still don't get a response, I'll tell the surgeon, are you sure that, you know, your electrode is sticking there, your electrode is right on the spot? And he tells me, yeah, there's some, you know, okay, maybe electrode is lifted up. It's not touching the brain substance or the gray matter. So, you know, these are the technical things. But just for you to understand, if you are on the primary motor cortex, you should get a response under 20 milliampere current. And remember, this is not a continuous current. Just give one pulse, a very short duration current, normally 100 to 200 microsecond. It's a very small duration pulse, and then you get a response. Based on where you get a response, you tell the surgeon, this is the orbicularis oris area. You tell the surgeon, this is the masseter area. Now, imagine the same tumor. You see this point number 2 and 3, I've lit it up. I've made it red. Can you see that? Can you see that, guys?
Yes.
So the point number 2 and 3, you know that this area is little midline, and you might think that there may be face and arm. So you should be recording. Now, for example, if you are stimulating 1 and you are recording from leg, obviously you're not going to see anything because 1 is far lateral, and it does not have leg responses. What I'm trying for you to understand is your communication to the surgeon You are talking to him, you're asking him, you are lateral medial and all of that, and then he tells you this. Based on that, you are seeing waves on a particular group of muscles. Are you with me?
Yes.
So if the surgeon tells you, now I'm a little bit in the middle of the tumor on the motor area, so I know that I may be getting signals from upper limb. So based on that, I have electrodes there. Sorry. So if I get a response, say from deltoid, I'll tell him that this is the deltoid from that particular, say for example, 2 was firing. When I stimulated 2, I got a response at deltoid. I'm going to tell him point number 2 is deltoid. Similarly, point number 3, I may get a response from hand, say APB, and I'm going to tell him that this is APB. The advantage of this is now the surgeon is not going to remove these areas. He's going to work around these areas and take the tumor out, but would not take the tumor from those areas, because if he takes the tumor from those areas, the patient would have permanent motor deficit. This would be permanent because this is gray matter. When the patient wakes up, gray matter is no more there for hand, for example. I hope you guys understand that. And then the last one will be 4. I'll tell the surgeon. Surgeon tells me I'm more medial now on the tumor, my electrode, stimulation electrode. Let's stimulate point number 4. And I stimulate point number 4. And I say, for example, I got a response, I got a response like that on tibialis anterior or a foot muscle. I'm going to tell him that this area is a foot area and this area is leg area or whatever it is. So I hope you guys understood that. Take-home message, I think I've already exceeded time. The take-home message for you guys today is to understand what is mapping, what is monitoring, to understand the basic modalities, these 4, at least the first 2, somatosensory evoked potentials and transcranial motor evoked potentials. And then if you can understand these mapping techniques, primary sensory cortex mapping, then primary motor cortex mapping, that would be wonderful. Do I have more time, John?
Yes, we have time for questions.
Okay. Let me just show you how it looks like. Say,
Sure.
For example, if you see this is screen, the motor mapping. If you see on the square picture that I have on the right side of your screen, if you see that there are blue wave that has formed, and then there's a purple wave. You see the blue is it's very small. It says BR, meaning brachioradialis. You see the pink one, it says ABB, LABB, meaning left ABB. So this is how I see a wave on those muscles, and I tell the surgeon that, listen, this is you are on the APB area or you are on the brachioradialis area. I think I'll take questions, although I have a lot more things, but I'll quickly. We still have to talk about. We still have to talk about subcortical mapping. We still have to talk about spinal cord mapping, D waves, screw stimulation, Kodak vena, cranial nerve stimulation. But I think that's 1.5 hours. You have a basic understanding of stimulation, recording, mapping, monitoring, SSEP, TCMAP, brain mapping techniques. And hopefully in the next few talks, when I get time, I'll give you examples and videos of other techniques and then how we interpret those signals. Before I conclude, it depends, it's a teamwork. I hope you see this slide, surgeon, anesthesiologist, and neurophysiologist. It's always a team game. Anesthesia, we need help from them. No muscle relaxant, for example, in motor evoked potentials. With the surgeons, there is the fundamental thing that surgeons talk about is do no harm. What we're trying to do is to save patient, do no harm. You don't want to send a patient who came to you walking and you send him back on a wheelchair. You do not want that. So one of the primary ways you can do that is to have a reliable electrophysiology setup and a reliable electrophysiologist. And that technology is going to help your patient. And then, as Rumi said, read it. Rakesh, can you read it for me?
Rakesh left.
Well, Rakesh left. Well, go ahead. Go ahead, Hira. You can read it. Want to put that up again? There we go.
Hira, you there?
Yeah.
Can you read that?
Yeah, I'll read it. Be a lamp or a light or a ladder. Help someone's soul heal. Walk out of your house like a shepherd. By Ruby.
Yes, so that's how I conclude, and I'll be happy if we can have a few questions.
Yeah, thank you, Doc, for a very complete, well-illustrated, comprehensive review of a subject that I knew nothing about. I don't know how much of the students knew. So we have a few minutes. Why don't we open it up and ask a couple questions? Do you have any questions for the Doc, Hira?
No questions actually, but it's a very good technique, and I think we should implement this in our centers as well in Pakistan.
Yeah, you know, that's very unfortunate till now, but I think Dr. Salman Sharif is looking forward to purchasing a system. I think a couple of hospitals in Lahore, they have a system. I don't know how much comprehensive they are doing it, but I'm sure it's a learning curve. In Rawalpindi, Islamabad, in the spine department there, in the CMH, the military hospital there, they are using all these techniques in the spine cases. So similarly, I think it's spreading, but I'm sure with time, more and more hospitals would start using all these modalities in their surgeries.
Well, you know, I was surprised to hear, Doc, that you are the only lab outside of the United States in the world. So that means a large part of the world is not really exposed to this or doesn't use it in practice. Is that true? Or
No.
They're just accredited.
Actually, no. You know, a lot of hospitals use it. For example, in Germany, in Japan, in Australia, they use it, but they did not go for accreditation. You know, for us, accreditation was very important. So, I thought that I should go for accreditation of my department, because being in the Middle East, you know, not a lot of people actually know about our hospital. But if you see our facilities and if you think that we are doing all of those surgeries, the surgeries that I showed you, we are doing all. Let me pull up that screen where I showed you. Say, for example, this screen. You say that it says brain surgeries. All of these surgeries we are doing in our hospital with electrophysiology, all of them. Similarly, the spine surgeries I told you about, selective dorsal rhizotomy, and you know, some of the other spinal cord tumors. So I think a lot of hospitals are doing it, but they did not go for accreditation, or the American accreditation criteria to get departments accredited is pretty tough. And you need to show that you are, the reading physician is qualified enough, whether he has some certification to read those things. The techs are qualified enough. You would be surprised, the 4 techs in Saudi Arabia were certified in the US as techs, were all my techs, and they are now working in UK and Canada. They left our place, sadly though, because they were acquired by the hospitals in Canada and in the UK. So you can imagine that the criteria is tough. So a lot of times you have those techs, but they are not certified, do not have credentials. So the American accreditation criteria is a little tough. I think people are doing it, but maybe because of the certifications of their human resource, they're not applying for those accreditations.
Okay. Slaven or Yosef, do you have any questions for the Doc?
I would like to ask a question, because you know, in Croatia we usually do this, and most hospitals have these opportunities, and all the operations you show, they're also kind of usual here. We have many centers who are performing these kinds of surgeries, but I wanted to ask you, there is a significant idea now in neurosurgery arising that awake craniotomy is better, even better than using monitoring or evoked potentials, because there has been some evidence, as far as I'm familiar, for example, with Professor Abdullah from the United States, who stopped doing these.
I was about to say that.
Yeah, because he can I please finish? Yeah, even though he saw that potentials are very, very, how can I say, that everything is okay, he noticed that sometimes patients wouldn't fare well after this. So he started doing the awake craniotomy, and he had much better results. So I just wanted to hear your comment. This was a really, really well-equipped lecture, and I think it would be nice if you could give more talks.
Yeah, I would love to
I'm
get
sure
more
it
notes
will.
and I'll
To
communicate with
broaden
John.
our understanding. Thank you. Thank you.
Yeah,
Yeah.
thank you very much. I know actually in Croatia, one of the legends of electrophysiology is Dr. Vedran Dilitis, and
Oh
I
yeah,
think
yeah.
he's from Croatia.
You know him?
I
Yes,
think he's from
in
Croatia.
Croatia.
And he's in New York. I was lucky enough to be trained by one of his fellows, by Vedran Dilitis fellow. I trained with him in the US. But anyways, coming back to your question, I read that paper from Dr. Rao from Washington, St. Louis, Washington University, St. Louis. And they talked about the use of awake craniotomy in aneurysm clipping. And they suggested that the motor evoked potentials did not really give them true positive changes. And they kept, and the patient woke up paralyzed, despite motor's attack. You know what, actually, this is, yes, let me answer you in simple words. Motor evoked potentials is a very, very, very authentic test, very reliable test. I've done now almost, I think, 10,000 patients, maybe one patient or two patients where I saw a change and it did not translate post-op. But the important thing here is to understand how you read motor evoked potentials. The paper that he published, he did not present any of his waves. He did not present the criteria that he used to stimulate. You know what happens is, in brain cases, my idea is to stimulate the minimum possible current with minimum possible pulses or trains and get a response. If you start very high, for example, in motor evoked potentials, the aim is to stimulate only the gray matter with your stimulation. You do not want to stimulate too deep. You want the gray matter to be stimulated, and then the current takes its course to the corticospinal tracts, and then brainstem, and then going down to cord and all the muscles in the limbs. If you stimulate deep, for example, my average baseline intensity is about 100 volts for a TCMEP, for a motor evoked response, and about 3 trains. I monitor EEGs as well, so patient is not very deep. I communicate with anesthesia, and he gives me just the best anesthetic level, so I don't have to go deeper. 100 volts and 3 trains. Now, if you stimulate, for example, 400 volts, a lot of I've seen, even in the US, they stimulate 300 volts, they're starting baseline, 300 volts, 5 trains, 7 trains, 8 trains. What happens is, you're not really stimulating the gray matter, you are going deeper. And sometimes your current goes that deep that actually it stimulates the brainstem itself, your current. Now, the surgeon has already, for example, caused damage to the gray matter. But you would keep telling the surgeon that the motors are good. Why? Because your current is reaching brainstem, brainstem is activated, the corticospinal tracts takes all the fibers, the current down, the signals down, and you tell the surgeon motors are good. But when the patient wakes up, this patient now has to use gray matter, move. But the gray matter was damaged because of ischemia or mechanical injury or whatever it is. So I think he may have some evidence, but I think his evidence is not very conclusive. We have to see how much he was stimulating, because that's why maybe he got presence of motors, but the patient woke up paralyzed. That's what he wrote in that paper. And I wrote to him actually. I never heard back from him on that. But I hope you understood that. The critical part for TCMEPs is minimum.
We thank you, Doc. We're going to wrap it up. We have another talk coming up, but I'd like to thank you very much for taking the time, and we look forward to having more talks, because I think we're just scratching the surface with this study. And thanks for the students for coming. So we'll say good night, and we look forward to your next talk, Doc. Thank you very much.
Thank you, John. Thank you, everybody, for logging in. Thank you. Bye-bye.